An 83-year-old man presents to the emergency department with a 2-day history of cramping abdominal pain, abdominal distension, and vomiting. He has absolute constipation. The patient is normally bedbound in a nursing home. The past medical history includes a laparotomy for appendicitis. He is on medication for Parkinson's disease. The plain abdominal radiograph is shown. Which one of the following is the most likely underlying cause of the problem? Here are your options: A. Carcinoma of the sigmoid colon, B. Sigmoid volvulus, C. Fecal impaction, D. Drug-induced pseudo-obstruction, and E. Adhesion obstruction. So each of the 5 options given in this question, they can be a possible diagnosis. But there are some cues given in the question, some details that are very telling of the diagnosis, and it will be very easy to come to at least 2 differential diagnoses from the 5 that are given just with this history. You don't even have to look at the radiograph. So if you're not somebody who can read a radiograph well, or who's not comfortable with radiographs and x-rays, then it's not even needed in this case. The radiograph is actually very, very telling. It's just one look at it and you can tell that this is this, but we'll get to that later. So first we'll maneuver through this question based on whatever information is given. So this is an elderly man, 83-year-old man with a 2-day history. 2-day history is a very short presentation, a very acute presentation, and the presentation of cramping abdominal pain with distension, with vomiting, with absolute constipation is very telling of intestinal obstruction. Add to that, for 2 days, this is a classic case of acute intestinal obstruction. Now, if this were to be partial obstruction, then there wouldn't be this catastrophic presentation of absolute constipation or obstipation or vomiting or very severe cramping abdominal pain. All these things you wouldn't see. If it were partial, it means it's an acute, complete intestinal obstruction. So that we've established. Now, intestinal obstruction can be of small bowel or large bowel, or it can be mechanical or functional. So we have to establish that next. Also, if you look at option A, carcinoma of the sigmoid colon, you wouldn't see a case of intestinal obstruction with carcinoma. It is there, it is possible, but it won't happen like overnight. It won't appear in 2 days. You would have partial obstruction to begin with, there'll be some symptoms, and the history will be longer. The history won't be just for 2 days. Suddenly, the cancer wouldn't grow up to a size where it'll obstruct the entire colon, or the entire small intestine or large intestine. That does not happen. It's virtually not possible. So that's why it cannot be carcinoma of the sigmoid colon, right? You need to have a history, a longer history, and some fluctuating presentation and some symptoms. There'll be rectal bleeding, and there'll be some mild pain, and it won't happen like this. So this is clearly not carcinoma of the sigmoid colon. The presence of colicky pain suggests a mechanical cause of obstruction. So mechanical cause as in it could be fecal impaction, it could be gallstones within the intestinal lumen, it could be carcinoma, out of which carcinoma we've already ruled out, or some extrinsic cause like volvulus or adhesions. So carcinoma we have ruled out, and the second thing that gets ruled out because the pain is colicky in nature and it's suggesting a mechanical cause of obstruction is drug-induced pseudo-obstruction, because that is functional obstruction. It wouldn't be mechanical, and mechanical is equal to catastrophic presentation, functional is equal to not a presentation which is like this, right? So drug-induced pseudo-obstruction is again out. So although it can affect both the large and the small bowel, and especially he's taking medication for Parkinson's disease, and also antihypertensive medications, they both can cause drug-induced pseudo-obstruction, but this is not something that this patient has. It's not because of his Parkinson medication. Now, he does have a history of previous surgery, and adhesion obstruction is the most common form of intestinal obstruction overall, causing mechanical small bowel obstruction. But again over here, if this were the case, if it was because of adhesions that have been formed secondary to his previous surgery, which happened for appendicitis, then again the presentation wouldn't have been, like, so it takes a lot of time for adhesions to form, and you will have like a slow onset of constipation, some dull aching pain on and off, and you would have a longer history. It wouldn't be like this. So again, E, adhesion obstruction, is out of the box. It's not, definitely not the answer. So now either it is B, sigmoid volvulus, or C, fecal impaction, and it can honestly be either of the two, because both happen in elderly people who are specially bedbound, and this patient is bedbound in a nursing home, and the presentation of cramping, severe abdominal pain and distension and vomiting and absolute constipation, they go really well with both these diseases. So for this, we'll have to look at the abdominal radiograph actually, and that will give away the diagnosis. Now, this is an elderly man who is bedbound and he has Parkinson's disease. So, when you have Parkinson's disease and you're old, or when you're of this age group, then already in this age group the peristaltic activity is a little bit reduced, one, and when you have Parkinson, then it is all the more reduced. It's subnormal, it's very, very below the normal peristaltic activity in an adult, right? So fecal impaction is a great possibility, because the fecal movement material, it's not going to be normal. It's going to collect in the colon and it's going to become hardened and it's going to block, and the presentation is going to be catastrophic. It's going to be the way it's described. And sigmoid volvulus is when a portion of intestine twists around its own blood supply, and this occurs at the base of the mesentery, and again it's the same. It's common in this age group, and especially with bedbound or hospitalized patients. Now let's look at the X-ray. This X-ray shows us a very large inverted U-loop of gas filled, this radiolucent shadow that you can see, this dark, really black kind of gray black kind of shadow that you can see is radiolucent shadow. This is what you can see, and you can clearly tell it's filling up the large colon. This is the sigmoid colon. So this is a sigmoid volvulus, because if it were fecal impaction, then you would be able to see fecal bolus on X-ray, radio opaque fecal bolus on X-ray, like a whitish shadow, like of this hardened fecal material on X-ray, and not this radiolucent shadow. This radiolucent shadow means it's gas essentially. So there is a lot of gas in this section of the colon and arising from the pelvis, which is classic of a sigmoid volvulus. So now we've established the diagnosis. It is B, sigmoid volvulus. Now, sigmoid volvulus is associated with a long and redundant sigmoid colon, and this long and redundant sigmoid colon, in medical terminology, it is called dolichocolon, and it is a predisposing factor to a close-looped kink from volvulus. So this presentation is of sigmoid volvulus as well as of fecal impaction, but with the help of the X-ray, we can come to a diagnosis of, a definitive diagnosis of a sigmoid volvulus. Now, how do you treat a sigmoid volvulus? And how do we treat or manage a sigmoid volvulus? It is by endoscopic deflation with passage of a rectal tube up past the region of the kink. And this is dramatically effective, and it's effective in almost all cases of sigmoid volvulus. And this tube, which we've passed up the rectum and beyond the region of the kink, and which allows all of the air to be passed, it can be left in situ while the patient's condition improves or prior to elective surgical correction. And usually sigmoid colectomy is done, but other procedures can be opted for, but this is probably the most common procedure. So it can be left in situ, and that is the decision of the surgeon what they want to do. But endoscopic deflation is the treatment of choice, and it is very, 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 very effective in cases of sigmoid volvulus. So that was it for this case. It was a little more difficult than the previous case, yes, probably a lot more challenging. That was a relatively simple one. This had a lot of scenarios coming up, along with you being able to read a radiograph, and if not, I'm sure now you at least know how to read, at least tell the difference between one with fecal impaction and one with sigmoid volvulus. And if you have any questions, or just write them down in the comment section below. And if there's anything else you want me to cover, because I'm going to post up new cases, and like I said, but it'd be nice to hear from you. So thank you. Thank you.